Good afternoon, everyone. Welcome to today's webinar, and thank you for joining us. My name is Marjan Linnell, and I'm a general pediatrician in Austin and a member of the Texas Pediatric Society. Today's webinar is co-hosted by the Texas Pediatric Society and the Michael and Susan Dell Center for Healthy Living at the UTHealth Houston School of Public Health. The goal of the Texas Pediatric Society is that all children in the state attain their full potential for physical, emotional, and social health, and the center's vision is healthy children in a healthy world. This webinar is the second in a three-part series on food insecurity here in Texas. Last week, we introduced this topic from public health and pediatric perspectives. Today, we'll be discussing clinic and community-based approaches. And finally, our third webinar coming up on March 9th will include policy approaches to food insecurity. Before we get started, I did want to make some brief housekeeping announcements. This webinar is being recorded and will be archived along with the presentation slides on our website at msdcenter.org. If you have any questions during the presentation, we're happy to have them. Please just be sure to enter them into the chat box. We'll have time for a question and answer session at the end of the presentation. Now, I'm excited to introduce our speakers today, Dr. Bocchini and Dr. Sharma. Dr. Bocchini is a pediatric infectious disease specialist at Texas Children's Hospital and Baylor College of Medicine in Houston. Her research interests include infection prevention and treatment in immunocompromised children, addressing vaccine hesitancy, and identifying and addressing social determinants of health like food insecurity in children and families. She's passionate about child health advocacy and serves as the Assistant Director for Advocacy Education at the Texas Children's Center for Child Health Policy and Advocacy. Dr. Bocchini also co-chairs the Texas Pediatric Society Committee on Infectious Diseases and Immunizations. Now, Dr. Sharma is a professor of epidemiology at the UTHealth Houston School of Public Health, as well as a faculty member of the Michael and Susan Dell Center for Healthy Living. Dr. Sharma is a behavioral epidemiologist with a specific interest in food insecurity, nutritional epidemiology, and diet-related chronic diseases in children and vulnerable and underserved populations. And she has a robust, federally funded research program in this area. More recently, Dr. Sharma is leading several COVID-19 related projects, including a Texas statewide COVID-19 symptom tracking initiative, analysis of COVID-19 data for the Texas Medical Center, Harris County, and Texas Department of State Health Services, providing recommendations for public health decision making and assessing the impact of COVID-19 on employment, food insecurity, financial stability, and other social needs among vulnerable populations here in Texas. Dr. Sharma is committed to serving the community, and on behalf of UTHealth, Dr. Sharma also co-leads the Health Equity Collective, which is a regional multi-sector coalition of more than 180 organizations collaborating on systems changes to improve health outcomes and health equity. Dr. Sharma is also co-founder of Brighter Bites, a nationwide nonprofit dedicated to providing fresh produce and nutritional education to low-income children and their families. I'm going to go ahead and hand it over to Dr. Bocchini to get the presentation started.
Well, thank you so much. I'm really thank you for the opportunity to speak with everyone today. I am going to be talking about how we at Texas Children's have worked to try to increase the screening going on for food insecurity, trying to connect our patients and families with resources for food insecurity. And I have to acknowledge fully, my partner in all this work is Michelle Lopez. She is a hospitalist at Texas Children's, a pediatric hospitalist who is out of town and not able to help me with the presentation today. Next slide, please. Thank you. Just our disclosures, I do some vaccine research as well, but not relevant to this presentation. Next slide, please. Thank you. So my objectives for my part of the talk today is really, again, to share our experience at Texas Children's. Michelle and I do research and also work on programming for the hospital, and really outline the processes that we take to try to maximize or optimize the yield of food insecurity screening in the healthcare setting. And we do that by several means. Try to use universal screening, try to make it more palatable, and show empathy with families. This can be a very difficult topic for families to feel open to really discuss with healthcare providers. We also really will emphasize in this talk how to build community partnerships and what community partnerships we've built, because we can screen, but we can't help address food insecurity without the partnership with these community resources. And also talk about how we can even do one step better, not just refer, but integrate these resources into the healthcare or clinic setting. Next slide, please. So just a little bit more about our background. Both Michelle and I are part of the Texas Children's Center for Child Health Policy and Advocacy, and we have been very interested in screening for social needs for some time. One of our first studies was actually a randomized control trial of 400 families who had children hospitalized at Texas Children's, and we screened for 20 different social needs as part of that trial. Half of those of the people who enrolled were given handouts to try to address social needs, and half weren't, and we followed everybody for 6 months. And while we saw many social needs, such as food insecurity, were very highly prevalent in our patient population, we saw that just by giving a handout, we didn't actually get many people enrolled in resources. And we became very passionate at that moment to try to do better and to find more ways of really building those relationships and getting people enrolled in programs that could do a better job helping them. We also learned a lot during this initial study about how healthcare providers can optimize the yield of food insecurity screening by developing a curriculum to try to help people with the screening process and try to help patients feel comfortable with the screening process. So after this initial study, which we did in the early 2010s, we started really focusing on developing a curriculum and how to optimize food insecurity screening in our institution. If you want to go to next slide, please. So we started, of course, with American Academy of Pediatric recommendations, and the current version of their food insecurity screening toolkit is amazing. I have a QR code if anybody's interested in pulling this up. If you haven't seen their Screen and Intervene, a toolkit for pediatricians to address food insecurity, it's excellent. And it talks through the process of preparing the clinical, preparing yourself and your team for screening, to do the screening, and then also what to do afterwards, how to intervene. Next slide, please. And our screening process throughout Texas Children's, for our research we do a more involved food insecurity screening, but for our clinical practice we use the Hunger Vital side, which is the evidence-based way of trying to screen for food insecurity, which is 2 questions. Within the past 12 months, we worried whether our food would run out, we need to buy more, or within the past 12 months, the money we bought just didn't last and we didn't have money to get more. So these are the 2 questions that are recommended by the American Academy of Pediatrics. Next slide, please. But we really did a lot about educating pediatricians and other healthcare providers throughout our system with how to use this Hunger Vital sign. Those questions can be jarring, and it can leave families, feeling worried about, actually talking about their experiences with food insecurity. One, it's hard for a parent to talk about that in front of a child, especially a verbal child. And 2, there's frequently, some shame and I'm concerned that, maybe the family would be reported to Child Protective Services, or, it'd be viewed as neglect to not be able to have enough food for your child. So we've done multiple focus groups and other, look to the literature to guide us on how to train, our healthcare system on trying to how to help people feel most comfortable with answering these questions. So emphasizing providing a safe, non-judgmental environment for caregivers to openly discuss food insecurity. Again, lots of stigma, unfortunately, around food insecurity. Taking a universal screening process, screen everyone so that people don't feel targeted by getting those questions. Also, it's very hard for a clinician to see one family and say, oh, you are going to be more likely to be food insecure than another. And then we went to the literature, also did some of our own research to see what's most sensitive in terms of method for screening. Written screening or electronic format screening does tend to be more sensitive. You get a higher number of people reporting food insecurity than verbal screening. Again, it's easier sometimes to write it down than to have to talk about it in person, especially in front of a verbal child. But also recognizing that we have families of a variety of different literacy levels, and that we need to have some verbal screening available for families if needed. Also, we service people who speak many different languages, and so making sure that we have the food security screening available in multiple languages was very important for our system. Next slide, please. The other important thing is that, again, if you're just going through, your usual intake with the patient, and then all of a sudden you ask the two-question hunger vital sign, again, these questions can be quite jarring. So we, taught people in our research and practice to use an icebreaker phrase when bringing up the subject of food insecurity. I'll give you an example of what I use. In Houston, many people are struggling with affording food for their families. We have some resources to help families with food. May I ask you 2 questions about your family's experience with food? I haven't had anybody tell me no. And I think using the icebreaker is wonderful because it really talks to your patients, your families, about why we're asking these questions. We want to help you. We're not trying to, just get the information and do nothing with it or be judgmental. Next slide, please. And then we did a lot of training. We continue to do training about how the clinicians and healthcare providers can help and address families if they do screen positive. We, again, sometimes try our best to discuss next steps when the verbal child is not present. Again, we don't want to make the child feel bad, and we don't want to make the caregiver feel bad for talking about these things in front of the child. Again, emphasize that everyone needs assistance at some point in their life, and try to minimize stigma by having positive messaging about addressing food insecurity and programs that can help with food insecurity. We have put together some signage that people can use and other things to try to decrease stigma, and encourage the parents to seek benefits for the whole family, especially the children, if they're reluctant to seek benefits for themselves. Next slide, please. Again, we try to talk positively about evidence-based ways of addressing food insecurity, like the Supplemental Nutrition Assistance Program or the Women, Infant, Children Program, 2 programs that have been shown to reduce food insecurity. And emphasize that these programs can be used to buy healthy food, to try to help your child stay healthy. That's our goal as pediatricians, is for the kids and the families to be healthy, obviously. We encourage people in the clinic who've had experience using SNAP and WIC to share those experiences with patients if they're comfortable doing so, to try to, again, share that these programs can make a positive impact in your life, or share that you've had other patients use these programs and it's been very positive. If families have used these programs before and have concerns, take the time to listen to those concerns and see if there are other ways of helping families if they don't feel comfortable enrolling in those resources again. Next slide, please. One particular area where we've recognized a lot of concern with enrolling in government programs is in families of mixed immigration status. One of our trainees who worked with Michelle and me in the past is Dr. Marina Michelli. She's a hospitalist now, but as a fellow, she was very interested in learning from caregivers of at least one parent in the household was not documented, about their thoughts on using public benefits. And of the families with undocumented parents, which was about a quarter of the people enrolled in our study, almost 30% reported discontinuation of public benefit use because of immigration concerns. There was lots of concerns of fear of being deported, et cetera. And so being able to be very sensitive and being able to find other ways of helping families and talking about these things was very important to us in our patient population. Next slide, please. So we also developed, and this is because of Michelle's expertise in breakthrough communication, a whole curriculum for people. It's about an hour on talking to families about sensitive topics such as money, social needs, including food insecurity. And I don't have time by any means to go through the whole curriculum, but just to give you a snapshot, really emphasizing the fact that you really have to nurture the conversation. And I know we're all limited by fast appointments, but identifying that somebody has food insecurity and talking through that can take a little bit of time. But the importance of listening attentively and silently, using body language to show empathy and that you have the patient's full attention, summarize the narrative and check accuracy back and forth with families is very important. Dialogue is very important. you don't mind going to the next slide. We teach people across our system to respond with empathy. We have several, mnemonics or help to kind of teach people about talking about these sensitive issues. So one of that is the pearls, kind of express partnership with the families and talking about food insecurity, recognizing that this is an emotional topic, show emotion when you're talking to people, apologize, I'm sorry that you're going through this. This must be very difficult. Absolutely show respect and recognize, what families feel about this topic, and then provide support. Next slide. One thing that we've seen over and over is frequently people will be identified as food secure, and the healthcare provider will basically dump a whole bunch of information on the family. Well, this is the Houston Food Bank, this is what SNAP is, and kind of go through all of it and say, okay, well, see you next visit, and we'll touch base on it. But when you dump all this information or download all this information is another way to say it. Frequently, it's hard to process it all, and so we've encouraged people to use it again, a dialogue, not a monologue. We call it the chunk and check, where you give little pieces of information, ask questions, have the patients kind of go back and forth as you talk about next steps to address food insecurity. This really does maximize adherence and recall when it comes to these types of discussions. Next slide. And the final part of our curriculum that I'll share with you is that we talk about art loops, which again is we ask for the patient and family's perspectives. And I think without doing this, it's really impossible to know that somebody has had a bad experience with SNAP or has fear that if their family uses SNAP, they can be targeted for deportation, et cetera. It's good to get this type of feedback to be able to help address concerns. Reflect, respond with empathy, and then teach your perspective. We've had amazing experiences working with the food bank and trying to help people, understand why we work so closely with them is very important part of this. Next slide, please. So just to show you kind of the impact of this training, and again, we've been adding to our training more and more. Some of our early studies, we were getting about a 13% positive food insecurity rate, and you can see every study we've done, overall we've been improving or increasing the number of people who feel comfortable disclosing food insecurity. I know food insecurity has also gone up through the pandemic as well, but our most recent Finnish study, we were at about 48% of children or of caregivers of children who were hospitalized at Texas Children's in our study were screening positive for food insecurity. We also branched out to our Texas Children's Health Plan, which is a Medicaid provider, and we screened families over the phone for food insecurity. Again, had the people who were doing the screening go through a similar training. Prior to our training, they were getting about a 3% positivity rate of phone screening. Afterwards, we were at about a 35% rate. So, we do believe that this training and education about how to talk about this does improve the number of people who feel comfortable screening positive. Next slide, please. So we worked very hard on our screening. Now, what do you do for your intervention? So this is just a figure from Feeding America about optimizing, addressing food insecurity in the healthcare setting. Yes, you do the food insecurity screening, but then, whether you decide to refer to community resources, host, food distribution on your site, or connect families to services that can provide support long-term, such as SNAP, WIC, et cetera. All of these things are good solutions, and we really try to do some of this on all three of those levels. Next slide, please. So first thing is building partnerships, and we help, Texas Children's has many clinics in the community in addition to our 3 hospitals. The community hospitals are located, in Woodlands and Katy, and then our main campus is in Houston. And so really working with local communities to build community partners and identify those food pantry sites that can have emergency food. We've connected clinics with those food pantries to make sure they stock healthy food as well. So again, building these relationships. I'll have 20 patients go to you once a week. Can you put, or once a month? Can you please, make sure to have produce, et cetera? And we've had really nice success with that. Host a community partner to provide on-site assistance, and I'll get into that a little bit more with the food bank. We more and more have Houston Food Bank representatives on site to help people enroll in things like SNAP and WIC, et cetera. assessing capacity is so important. When we started with our relationship with the food bank, one of our programs, we completely overloaded one of their programs, and we had to work together, acquire funding to hire more people to be able to tackle all to take in all the families who were referring to them. So, again, I encourage people to start with your local food bank. They're amazing resources, and really work together to be able to service the population. Next slide, please. Again, looking through identifying your community resources even beyond the food bank. Many of our clinics in the community have built partnerships with, again, local food pantries, other programs. There's one program called Kids Meals that will drop off lunch to families in the community in need. And so, we've have a list of resources that people can use to be able to identify local resources that they can then share with their families and make the connection. Texas Children's uses Find Help, which is a national website that allows you to make active referrals. So you don't just give the patient the phone number to the resource, but you can actually give the resource the patient's information through this website, and then the community resource can actually connect with the family that way, which I'll show you in a minute, can really increase the family's ability to enroll in the resource, or they end up enrolling in the resource more. Next slide, please. So again, referring families to resources is what we do every day. And again, this active referral process can increase the enrollment. In our studies, we've seen an increase from 5% from that initial study when we just gave people the phone number to the Houston Food Bank, to over 75% when we have active referrals. And so that active referral means we screen, we give the family's information to the resource like the Houston Food Bank. The Houston Food Bank reaches out to the family, and then they also get back to us and tell us how that connection went. Were they able to successfully help the family apply for SNAP? Were they able to link the family to a food pantry? And that's been amazing. And these active referrals are frequently online. We started this during the pandemic, and so we put the patient's information into the Houston Food Bank's electronic system. They reach out, and then we get the feedback through the electronic system. But again, post-pandemic, or at least in this phase of the pandemic, we've actually had Houston Food Bank representatives at our hospital, at our Katy campus, in some of our clinics, like our endocrine clinic, our clinic for children with diabetes. And the plan is to have more and more people on site so we can have that direct connection. Next slide, please. Again, the Houston Food Bank has been amazing and has really led to the success of us being able to work with families on food insecurity. We work mainly, Michelle and I work mainly with the First Link program, again, which is the program where the Houston Food Bank takes the patient's information and reaches out directly. The navigator, community navigator, who actually connects with the family, will screen the family. If the family is not enrolled in programs like WIC and SNAP, the Houston Food Bank representative will help them fill out the application. They will also help connect families with local food pantries. And as the family still is needing additional support, one of the things that was very clear with our research is you can have people enroll in SNAP, but it doesn't necessarily completely take away food insecurity. I mean, many studies have shown that. And so any money that the family has is good, because that's more money that can go. And so the Houston Food Bank has a resources coordinator that if the family is still struggling after enrolling in SNAP, the resources coordinator actually interviews them and screens them for 16 other social needs. So if the family has difficulty paying utilities, they can, enroll in utility assistance, apply for help with housing, multiple different things, apply, for health insurance, multiple things to try to support the family. And this has been amazing. So from 1,600 completed referrals that we've made to the Houston Food Bank, this was about a year-old data, 85% of the families successfully applied and enrolled in SNAP, 48% were linked with food pantries, and another 34% qualified for rent and utility assistance, which is huge. So again, the Houston Food Bank has been an amazing collaborator for us. Next slide, please. Lots of other interventions. We have clinics who've had mobile food pantries come, once a month or so, and advertise it so that the patients can come to get food at that time. Especially pairing that with talking about the importance of healthy food and produce. This has been really nice at a couple of the clinics. Next slide. On-site pantries, this is something that we're hoping, to work towards. There are other examples of healthcare providers in the Houston community that are already doing this. This is wonderful, where you can actually come to your follow-up appointment and then stop by the on-site pantry. So that really does, help with barriers like transportation, et cetera, for picking up healthy food. Next slide, please. And finally, I know Dr. Sharma is going to talk about the Food RX program, but we do have several Texas Children's clinics who are enrolled in the Food RX program as well, which is amazing. And I'll let Dr. Sharma, share her data because it's pretty exciting. Next slide, please. So because, as we've gone through all this, we've realized that, the Texas Children's community and others need to have a process. Each clinic, takes its own, process, has to identify a food insecurity champion, et cetera, to really make this successful. So we put together a food insecurity kind of action plan. If you're interested, you can use this QR code, but it offers different trainings. We've developed trainings that we can do online or asynchronous ones where it's a module that people can complete to, again, learn more about food insecurity screening, promotional materials people can download, print, and put in their office, talk about, how to develop food insecurity interventions for the clinic, et cetera. Next slide, please. And many of the resources that we have are all on this kind of Padlet website that we put together as part of the action item. Next slide, please. There's another QR code as well. So our current progress is that, Texas Children's has committed to doing food insecurity screening across the entire organization. So that's every patient who comes to the clinic, every patient who comes to the hospital, every patient who comes to our emergency room. And, the goal is to make active referrals for all families that screen positive. It's a work in progress, but it's really moving. And the Houston Food Bank is our primary partner. Again, we're having more and more people on site, which is really exciting. Next slide, please. And I think that's the end of my talk. I'm happy to answer any questions. And now we can hear from Dr. Sharma, who's done some pretty incredible things and has really wonderful data to show us.
Thank you so much, Dr. Bocchini. That was wonderful. It's like you teed my presentation up. We are in the Houston Food Bank fan club, I think. So I'm Shreela Sharma, and I'm going to speak a little bit today about the community healthcare and academic partnerships that we are working on. Next slide. So food insecurity and a healthy diet are intricately linked. And the important question is, how do we as a society ensure stable availability of healthy food in food insecure populations? And as you saw just a minute ago, there's a variety of programs like SNAP and WIC and also the broader Feeding America network of food banks and food pantries that are available. And there's also several food access programs to reduce food hardship during emergencies, such as emergency food programs, but they may not necessarily be designed to ensure steady availability of healthy food in food insecure populations who are struggling with diet-related chronic diseases. Now, there's the Food of Medicine menu of programs that are fast gaining popularity in the US as the type of programs that leverage interaction of at-risk patients with the healthcare system as a strategy to deliver evidence-based food and nutrition interventions. And this set of Food as Medicine programs include medically tailored meals, medically tailored retail, and food prescription programs. And for today, I'll focus on the food prescription set of interventions. Next slide. So overall, just to level set with everybody, the food RX or the food prescription interventions, the evidence is promising. There's, a latest report that was also released last November from the Aspen Institute. There's meta-analysis, systematic review that have demonstrated promising impact of food RX interventions on food insecurity, increasing consumption of healthy food, and also improving health outcomes such as hemoglobin A1C in at-risk populations. However, the studies are plagued with small sample size, perhaps lack of a control group, a weak pre-post type of evaluation design, And the reason these designs can be, this evaluation can be a bit challenging because it's then difficult to attribute any changes that we're seeing in outcomes, and particularly health outcomes, to the food RX intervention. And the reason this is gaining popularity is because of the potential reimbursement pathways as part of value-based care reimbursement. So payer groups would potentially reimburse for these types of interventions. Next slide. So today, I'll share a few of the partnerships that we are building to essentially build the real-world evidence base for food RX interventions. And one of these partnerships is with the Houston Food Bank, and it's a very robust partnership around assessment, design, capacity building, monitoring, and evaluation of their food RX program. And I would be remiss if I did not mention that trust is really the underpinning of this relationship that has been built over the years of working together. I'm definitely in the Houston Food Bank fan club. Next slide. So many of you may know this, but it's the Houston Food Bank is the largest food bank in the US, serves close to 1 million people across 18 counties in Southeast Texas. And our partnership, specifically around food RX, started right around 2015 as part of a large Harris County Build, a collective impact initiative to build a healthy and a sustainable food system in the North Pasadena region in Houston. And that's a region that has very high rates of food insecurity. And so we partnered with the Houston Food Bank. We were the evaluation backbone to evaluate the implementation of a food prescription program across 3 clinics. And this was a pilot. This was a first implementation of the food RX in our region, and showed a 94% decrease in food insecurity among the patients who participated. These were about 172 adults who were food insecure. Now, the challenge with this evaluation was that it had a small sample size, no comparison group, and we mainly looked at just feasibility of implementation of food RX in our region through these partnerships. And so we did not look at health outcomes impact. So fast forward in 2020, the Rockefeller Foundation funded us to evaluate a retrospective evaluation, secondary analysis of 3 years of implementation of the Houston Food Bank Food RX program. And here we looked at clinical effectiveness, cost effectiveness, and we also did a very thorough assessment of patient lived experience as part of the program, a food pantry lived experience, provider feedback, and also the systems and process analysis. Next slide. So just, this is what we had in terms of our sample. We had 21 healthcare partner sites across the greater Houston region. As you can see, it's a pretty robust set of different types of healthcare partners. And then the program was implemented through about 21 Houston Food Bank Food for Change markets, and that included food pantries as well as the mobile food trailers. Next slide. So how does if y'all don't know how the food bank program works, it's essentially a very robust partnership with the healthcare partner, and the healthcare partner screens their patients for food insecurity, just as you saw with Dr. Bocchini. How they do it at Texas Children's. So using, most often it's the two-item hunger vital sign that's used to screen patients for food insecurity, and then they get offered the food prescription program if they screen as being positive. Many healthcare clinics have a comorbidity associated with the screening. So either the, oh, sorry, can you go back one? I'm sorry. So either they get, they have a diagnosis of diabetes or perhaps some other comorbidity, and then they get enrolled in the food RX, and they get then to go to any of the Food for Change markets. Next slide. And they can redeem for up to 30 pounds of fresh produce plus 4 healthy items like lean protein, low-fat dairy, whole grains, and they can redeem twice a month. for any of the foods. And you can see it's sort of like a client choice model, so which is really nice because it's the experience that one would get like they were in a grocery store. And so patients get to choose within this particular formula on what they want to redeem. Next slide. So the primary aim of our study, and I'm just going to very briefly present what our results are, but the primary aim was to conduct this comprehensive 360-degree evaluation of 3 years worth of data. So we looked at clinical impacts on cardiometabolic outcomes. Hemoglobin A1C was our primary outcome, and we had a group of of patients who were enrolled in the program and redeemed their prescription. And then we had a comparison group of those who enrolled in the program but never redeemed their prescription. So, and our total sample size was about 2,028 patients. And then we also conducted some cost effectiveness analysis and did a lot of in-depth qualitative work to look at perceptions and experiences across the board, from the healthcare partners to the food pantry staff to the patients themselves. Next slide. So on the left-hand side, I'm going to talk left to right. So on the left-hand side are our main results. So the control group were patients that did not receive were enrolled but did not redeem their prescription. And the exposed group was patients who were food insecure, had a comorbidity such as obesity, diabetes, or were pre-diabetic and redeemed their prescription. And it's important to note that in any of these food RX models, patients are also receiving standard medical care as part. So it's food RX plus standard medical care. That is usually sort of the model for implementation. And so what we saw was a statistically significant decrease in hemoglobin A1C among those who participated in food RX as compared to those who were enrolled. Oh, I'm sorry, enrolled but did not participate. So there was a net difference of almost a 0.3% decrease in A1C between the two groups. And then on the right-hand side, what we saw was that dosage did matter. And so what you see is that at the very bottom, 34% of those who had no visits but received standard medical care had more than a 0.5% decline in A1C as compared to the very top bar where the number increased to 50% of those among those who had 7 or more visits saw a 0.5% decline in A1C. And you can read more about this paper that was just published. My colleague and co-PI, Dr. Nalini Ranjit, is the first author on that paper that was just published in BMC Research Notes. Next slide. So we also saw that A1C, so there was a very clear dose response. So dosage does matter when it comes to food prescriptions. And that is really probably the most important takeaway from this evaluation. Because whichever way we saw it, percent improvement in hemoglobin A1C was directly related to frequency of visits. And just to give you a benchmark, the average A1C of the patients who participated in the program, as well as those in the control group, was over 8%. So these were patients with high A1C levels as well. And then we also saw, cost effective, that the program was highly cost effective. I don't have time to go into those results today. Next slide. So one of the things we did is also map out the potential wedge points for improvement in intervention program implementation for future efforts. And some of the big things we saw, which also Dr. Bocchini emphasized, was making sure that there is a warm handoff and a care coordination and communication of the food prescription. Just because you hand someone a prescription doesn't mean they know how to use it or when to use it and what to do with it. And so that warm handoff and care coordination really was critical, making sure that that this was being reinforced and that everybody received information that this was a health-focused nutrition intervention and not just a food handout. And so that needed to be re-emphasized across the board, especially among the food pantry staff who do intersect more regularly with the patients. So there were a lot of wedge points in terms of improvements that we provided back to the food banks as well. Next slide. If you can click one more time. So in summary, we did see that there were significant improvements in the A1C levels and that this was dosage dependent, and that that multi-institutional food prescription programs that involved partnerships across 21 different healthcare partners, and also across multiple pantries around the region. And it's complex, but definitely feasible and also effective. And we also realized after our deep dive that relatively small changes to implementation strategies and structures, especially in the workflow, whether it's workflow in the clinic or workflow in the pantries, can have a significant improvement in program uptake and reach. And I'll tell you one thing in this space, we learned that the biggest barrier to food insecurity was transportation for the patients. Next slide. So I wanted to just also mention that we've taken a deeper dive into some of our partnership. So for example, here we have a partnership with the Houston Food Bank and Harris Health System, which is our county hospital system, not just on the evaluation of the food RX, but also to strengthen the capacity for nutrition education in healthcare settings who are implementing food prescription programs. So as part of our ongoing efforts with Harris Health and Houston Food Bank, we conducted a system-wide assessment and training of Harris Health dietitians, and using a patient-centered design, implemented a culinary nutrition education approach to complement the food RX efforts. I mean, let's be honest. Nobody wants to eat a sad salad just because it's healthy, right? And so one of my colleagues always, who is an expert in culinary nutrition, always said that, and it's so true, that if we want to see behavior change, then flavor has to be the mediator of that behavior change. And so culinary nutrition allows for that hands-on training of the patients and also the dietitians in teaching the patients on how to use the food that they're getting through food RX. So we have a lot of publications in this space as well. And if you go to our Nourish program website on the Dell Center, you will see there's a ton of resources available publicly as well. Next slide. So one of the next steps, so all of this work that we did with the food bank was secondary analysis of data that was already collected. We want to now go in prospectively and assess the evaluation of some of these emerging partnerships. So for example, there's a partnership that the Houston Food Bank has formulated with a managed care organization in our region in implementing food RX in high-risk pregnant moms. And that's a group that's really critical, because that's the part where you can impact both the mother and the baby, and we'll be assessing the impact of the program on both pregnancy and birth outcomes. And this is really to build the evidence base around the reimbursable pathways as we move into the future of value-based care reimbursement. Next slide. And then last but not least, I want to highlight, I would be remiss didn't mention the space of pediatrics. And so last but not least, this relatively new partnership with Brighter Bites and UT Physicians on food prescription programming in pediatric populations. And for those of you who don't know Brighter Bites, it's a national nonprofit that implements an evidence-based program that combines access to fresh produce. So this is just produce, this is Produce RX, plus nutrition education in low-income communities. And the largest footprint of Brighter Bites is actually in schools. It's implemented as a school-based food co-op, but through this partnership, we are also implementing a Produce RX with UT Physicians. Next slide. And so what we're doing here is we are actually doing a comparative effectiveness randomized controlled trial And we are evaluating the feasibility and effectiveness of 2 types of food prescription strategies. And I'll talk about that in a minute. And we have a usual care comparison, a wait list usual care comparison cohort. And the reason we wanted to try different types of food prescription strategies is because we actually don't know in the literature, is one better than the other? What does dosage look like? I mean, if you're thinking about food as medicine and want to talk about reimbursement pathways, we need to understand, well, what are the predictors of implementation success? What are some of the best practices to adopt and implement as we're thinking about food RX or produce RX programs? And so we are working primarily with 2 clinics that are serving Medicaid eligible children ages 5 to 12 years. Next slide. And so group 1 is getting a home delivery of produce boxes. And you can see these are real pictures of the super cute kids on the right. They're getting home delivery through DoorDash of 8 to 10, 12 different kinds of fruits and vegetables. About 20 to 25 pounds equals about 50 servings every 2 weeks. And this takes away the inconvenience of transportation, right? So, but it does require you to sort of allow someone to drop off a box of produce at your doorstep, and does not allow for choice architecture. So that's the part that's, you know, we're trying to test out. The second group gets a fresh produce card. So this is medically tailored retail that we're doing. So every 2 weeks, they get 25 pounds that they can redeem at various grocery stores for just fresh produce. And so we've been working, we've been implementing this. Everybody gets a very robust nutrition education program through Brighter Bites. We also have a mobile app, so feel free to download it. It's freely available to everybody. Everybody gets the mobile app, and then our comparison group just gets the nutrition education component, and at the end of our evaluation, will get access to the intervention as well. Next slide. So we're doing, again, a robust evaluation. We're looking at child dietary intake, parent dietary intake, feeding behaviors in the home, and also several health outcomes, because we want to see, well, you know, and we're following the children for about up to a year into the program. So we want to make sure that we give enough time for the intervention to have an impact. And of course, food insecurity, as well as program satisfaction, acceptability, so on and so forth. So there's several outcomes that we're tracking as well. Next slide. So I want to end by, as I shared, you know, several different models in just a few minutes. So I went pretty fast through them, but I want to just share, I wanted to give a flavor for what we are trying to do in this space. We are trying to build the evidence base on whether these strategies are moving the needle on food insecurity, on improving diet, on health outcomes, because ultimately we want to get to that reimbursement conversation as well. I think it's, you know, it's important to know that while factors such as our race, ethnicity, socioeconomic status should not play a role in how healthy we are or how long we live, unfortunately for many of our communities, they do. And what's you know, a good thing is that this problem, this very pernicious problem of food insecurity and social determinants of health needs in our region, they cannot, they exist, but they cannot be addressed by any single agency. And so the nature of this work lends itself to collaboration and partnership. And so, you know, that is one thing that we are working very hard at the School of Public Health to make sure we're building those partnerships. We are also recognizing that this is not going to be a one shoe fits all. We are going to need a menu of these solutions and interventions subsumed within a broader ecosystem of care coordination so that we can meet our patients where they're at. And finally, you know, our call to action from a research perspective is to build the evidence base towards this menu for reimbursable pathways. And that's going to require us to make sure we are asking the right questions. Also reimagine our data systems so that we are ensuring they're equitable. And then also a system science approach, because partnership and collaboration is not just happenstance, it needs to be intentional and just a part of who we are and what we do. Next slide. I think that's all I have. So thank you so much, and I'm happy to answer any questions.
Dr. Sharma and Bocchini, thank you so much. That was amazing. We do have some really fabulous questions, so I was just going to roll right into those if that's okay with y'all. Okay, the first one that rolled in is, as a medical professional, can you please address the following situation? Families are enrolled in SNAP, but food purchasers in the family may misuse those benefits by buying non-nutritional consumables such as soda pop, high-calorie foods, drinks, and snacks, as well as highly processed pre-prepared foods. Not sure which one of you guys wanted to take that one on for us.
I mean, I can speak as a dietitian that you're right that patient, that's where the alignment with education needs to come into place, and it really starts, it's across the board, whether it's the from the provider side or the the nonprofit side. There has to be that consistent sort of messaging and education on how do you use your SNAP provisions. I will say SNAP has been proven time and again as one of the most evidence-based strategies to address food insecurity, and it does provide a very, very important safety net for our patients.
Absolutely, thank you. We did have another question, actually a couple questions, but I think they're pretty much the same. What platform are y'all using for the active referral process? I think this one may have been more tailored, I think, to Dr. Bocchini with that active referral y'all were mentioning.
Is it
Yes,
Find,
I'm sorry.
Find Help?
Yeah. It wasn't letting me unmute. I'm sorry, but I loved the answer that you said about SNAP as well. We use two things. One is, findhelp.org is a way that the whole organization, and then we also have a direct program that the Houston Food Bank has, where we actually put information into their PTIC system. We're trying to actually integrate that system with our electronic medical records, so that will be like our one active referral system. But that's been the barrier of just working with the food bank system in the past. But we're working on it.
Thank you. How about we take on, how can the clinic enroll in the First Link program?
So if you're in the Houston area, if you happen to see the QR code I put up, you can actually, one is a red cap survey where you can actually contact me, or you can just email me and I can connect you with our contact with the food bank, or you can reach out to the food bank. I mean, I think it was probably like 10, 12 years ago where I just cold called them to kind of start our relationship. And I mean, it's been amazing. But I'm, happy to, to share the contact with these. They've been absolutely amazing. I love the Link program. I am a huge Houston Food Bank fan, you put it.
So I'm really excited that someone asked this one, because this is one of my big ones, not being in Houston. So how can we take all this great work that we're hearing about in Houston, or to kind of extrapolate that in other large urban areas, and make it potentially a statewide program and accessible to academic and community clinicians, as well as in more rural areas?
Go ahead, Dr. Bocchini.
Well, no, I love that question. And, the nice thing is that all the food banks in Texas, at least, are connected. And so, we at Texas Children's, we have patients who come to our hospital who are from all over Texas. And so we've actually been able to work with our food bank to connect them with their local food bank to be able to provide resources. Again, I'm happy for people to reach out so that we can, try to connect. But I agree. I mean, I would love to see some looking for some funding for some more statewide interventions, because I really think that a lot of this could be replicated with other local food banks. course, you'd have to build capacity, and that's something that, you know, you'd have to work with together. You know, part of our training does include where to look for funding. So, you know, we've had funding from local grocery stores, from local foundations. There are, you know, some grants available. And so, you know, if people are interested, I'm happy to share some of those resources for to find funding to be able to build capacity with your local resources. And there was one other thought that I'll let you know if it comes back to me. I don't know if Dr. Sharma, did you have other thoughts?
I will just add that I think the magic word that you said was that capacity building piece to implement. And so that's something that we have worked with healthcare organizations on, is how do you plan to implement this in a, especially I'm talking primarily about food RX type of interventions, and just how do you design, assess, because a big part of this is adoption, right? You can have a great program, but if nobody redeems the prescription, then, you know, it's not going to be successful. And so our framework is first learn the lived experiences of your patients in your community. Rural areas looks very different from urban. Even within urban or within rural, there's just very different ways on how people procure and consume their food. And so big part of that planning phase is just understanding the lived experiences and centering, using that human-centered design to then design your food RX, and then, you know, the implementation and what do you want to learn from it. I think that's another part. One of the things we're doing with Harris Health, for example, it's sort of a learning health system model where you're continuously implementing, monitoring, evaluating, and then having the feedback loop in your, so that then you can institutionalize it. I mean, ultimately that's because food, you know, Harris, I didn't mention this, but Harris Health actually has food pharmacies. They've co-located inside their clinic system, which is a very integrated model. It's probably the most integrated model you can see for these types of programs. So it does require, you know, a more in-depth workflow discussion and implementation. So happy to, you know, share that as well if people are interested.
And I remember what the last thing I was going to say. I'm so sorry if that's okay. The question also touched on rural-based solutions, which are very different from urban. And you know, I still think enrolling in programs like SNAP and WIC are helpful if people are not enrolled. But then how to get food and overcome the transportation barriers can be even more of a challenge in the rural setting. I know some of our you know, clinics and collaborators who are a little farther out have looked into some food delivery programs, which don't work as well for some produce, at least you know, depending on who you're getting to deliver the food. But it is something, you know, another option for rural communities is to look at some type of food delivery program with a local food bank.
Fabulous. It does look like we're running out of time, but I can't help but ask one last question that I thought was fabulous, and I think it came up twice. Can you talk about the sustainability of the project, specifically in terms of funding the food RX?
Yeah, so I think that's a great question. And so in term, there's, you know, a lot of it, the food bank is supporting it, for example, through the philanthropic funds that they're raising. But I think what we are pushing for is ultimately thinking about those reimbursement pathways. So the MCO food bank partnership that I mentioned, you know, thinking about MCOs putting these types of programs as part of their operational budgets would be phenomenal, right? So we can bring these types of models. So I think sustainability is a very important question, especially as healthcare organizations scale the screening side of things. You know, how do you make sure these programs are implemented and sustainable? Yeah.
Fabulous. Well, thank you both so much, Dr. Bocchini and Dr. Sharma, and thank you for all of our fabulous attendees. It sounds like we had a great turnout. We really appreciate everyone being here. Please remember that this webinar will be archived, on the center website at msdcenter.org. And thanks again. Bye, you guys.
Thank you.